earlier on, there was a question from Judy Deutsch to Nicola specifically. And the question was, did you look at conference papers when you review the literature to see patient and clinician involvement in the tech design? Judy, I invite you to unmute your mic and discuss that directly with Nicole if you wish. So off you go.
Hi, Judy. Hi, Judy. Thank you. So that was really helpful, actually. And I think I may have sent you the reply as a direct message a little earlier as well. So this was a pre-registration dissertation. So not at this stage, no, but if we, and I hope we will be going on to work it up to a publication, then yes, I agree with you. I think there's a lot of literature that perhaps we, perhaps would consider grey or in those conference proceedings. I mean, I know I've put work in there that perhaps hasn't then gone on to peer review publication. So I think you're right. We need to find a way of capturing that and assessing its quality within the overall piece of work. But as I say, at this stage, in full acknowledgement to the student, it's a pre-reg dissertation that's just been handed in, and hopefully it will be of a standard that we might be able to work that towards publication and include that work. So thank you.
Yeah, no, I think that's one of the challenges in this technology literature, that it kind of lives in two worlds, right? It lives in the conference world where you might be going to technical meetings and presenting it. And then when it crosses over into the, rehabilitation literature, some of that information doesn't always port over or doesn't port over as much. So it's almost like we're always having to consider exploring IEEE databases to capture some of that. But it is a challenge for sure.
It really is. And I don't think it's that we think it's not happening, but perhaps it's not being reported. And that's the difference. Absolutely. We need to find a way of establishing, because actually it's so important that we do find a way of reporting and capturing that really important information, because it feeds back into that iterative, inclusive innovation cycle.
Yeah, I think we as physiotherapists have to take ownership in the development of these devices. I mean, too often we kind of, see what's out there and then see whether or not we want to use it, instead of helping in the actual development of what we actually need. Mm-hmm. And I think that's the key. I mean, I see you nodding madly, and I've been sort of singing this tune for a while. Yeah. Okay, I want to just take a little step aside, and I don't know if I can actually see this or do this. Somebody has their hand raised. I'd like to address that. So the person with your hand raised, Kaz, I believe. I can't see all the screens, but if you would like to unmute yourself, and do you have a comment to make in this regard?
Yeah, I did. Thank you so much for your brilliant presentations. That was really excellent. And I just, wanted to add in, I'm a physio, I work in Bristol, and I've been actually developing technology myself, having seen the need for intensity of practice and some simple, affordable things that could be used to help people get on their feet a little bit more. And I think it's definitely has shown to me to be so important to do that PPI level, and certainly in terms of grant funding and looking at actually getting funding to develop this, I have been required to have that PPI and that stakeholder involvement with all of my colleagues and lots of patients, but there isn't any, like you say, anywhere to actually publish that and make that known about. But certainly it is a prerequisite for all of the iterative processes and the developmental stuff that we've done. And I think for the research that we do now, we're looking at a more mixed methods design so that we can actually run the feasibility tests as well as collect really, really valuable data, because actually it is that qualitative aspect that has proved to be so important to actually make this device that we've been developing much more relevant to patient use and clinical use. So yeah, I just wanted to chip in with that because it was just a really pertinent conversation. Thank you.
Very good, thank you. I wonder if people can raise their hands if they've also been involved in technology development or modification of technology in their own environments. Has anybody been involved in that? Yeah, I see a few hands going up. Great. Well, I think we have to step forward, be a little more vocal, a little more aggressive, maybe, but maybe assertive is a better word, because there is a lot of technology out there, especially with the advent of the lower cost devices. Okay, we had a second question. We had a question from Cherry, who commented that maybe in the US, the technology is being used more often. I think that's what you meant, Cherry. If I'm wrong, please unmute yourself and maybe ask your question directly.
Yeah, thanks.
Okay. Yeah.
Thank you. Thanks, Mindy, and thank you everybody for your contributions. My comment was really based on an observation of coming to visit some units in the US as part of a conference tour, and was, majorly impressed by the amount of technology that I could see, and sort of in terms of upper limb technology being utilised in many programmes, particularly by the occupational therapists. And this is, in my experience, quite different to what we have, or the experience within the UK, where it seems to be more difficult to get treatment embedded as used as part of an adjunct to treatment. Just wondering whether or not it was actually, in terms of it was just, is technology used more in the US? Partly thinking because the healthcare system is different to ours, so I recognise that. So it may just be that sort of context-specific aspect.
It's a really hard question to answer. We try to.
Sorry.
Yeah, we know it's a good question, but it's hard to answer. We try to actually ask that or have statistics for that. We did this thing in Canada where we tried to look at what was the uptake of technology, okay? And we didn't see anything in the literature in terms of how physical therapy departments were uptaking technology, any kind of technology. And we were looking for VR and game applications and adapted things like that. We only found one really good study from the UK that talked about using exercise machines for cardiac rehab. Okay, where there was a nice uptake. And of course, that in 2019, there was a huge spike in that uptake because of the pandemic and the need to do things more remotely. So I think we don't have those statistics. We can't even answer the question. We can survey people. Somebody has to maybe do a good survey on that, I think.
Thank you. Thanks. We can try and address that gap. Thanks very much.
Okay, great. Would somebody, one of those panelists, like to speak about or speak to the question about uptake?
I think part of the problem is that the issue of uptake is so multifactorial, right? So there are patient preferences, and then how much training or how much self-efficacy do clinicians feel they have about the use of the technology that's available, and the availability of the technology in whatever country you're practicing in, as well as how much institutional support there is for the use of these technologies, both in terms of clinician training as well as time and space allotted to where this technology can be implemented and used with the clinical population. And so I think all those factors differ so much from one country to another that is part of why it's so difficult to determine if there are differences and to what extent with regards to uptakes. Plus, the devices that are available differ so much from one country to another that again is really hard to compare.
I can also comment about in Sweden, as I know the technology uptake is quite slow. Mostly it was also the regulation of the health system. Everything needs to be very well evidence-based and need to be tested so many times. And it takes still a few more years before the actually healthcare is being able to buy in those things. So what happens that we usually maybe do studies, and this way we implement smaller scale in some places because they have interested therapists in these places and driving the question. But for my clinic, the stroke rehabilitation, many years we had we put quite early up those Wii gaming and Nintendo and this kind of VR gamings, and they were used in the beginning, and then they were used a little bit less, and the interested person was moving somewhere else, and then they were more standing alone and not getting so much played. So we still have them, but I don't think they get used as much as they should, maybe. And the other part that you also presented, Sujata, is that maybe the activity monitors have find some way to the clinical practice in some places to monitor the physical activity in general.
So, but our question for you is, how much do you think is it due to the therapists themselves being unfamiliar with the technology versus the technology itself not being adequately designed or addressing, like, is the lack or the reticence for the uptake, is it more about the therapists don't want to change what they're doing, or is it because the devices themselves don't address things that they, where is the actual problem from your perspective?
That's a very good question, because I don't have a perfect answer, but I think it's both ways, actually. I find that many therapists are busy. They have very little time to even sometimes think about those things and how to get it into the everyday work. And many are a little bit afraid of technologies, I think, know how to use, and sometimes it's like computers, things don't work always, and the batteries, and you have to maybe load up things and look at the different variables that you don't understand. Because I think the more simplest technical devices would be readily available now, but they still are not really coming in. And of course, the clinicians need to understand that it will be useful for the patients, as like everything. Even we struggle also with just doing standardized assessments, to be feeling that that is something that is useful for me and for my patient. But here, I think the knowledge is the main barrier. When you know about things more and you know how to use them, then there will be use for you and for your patient.
Yeah. Nicola, do you want to comment on that?
Yeah, I agree. It's very difficult, and it comes back to this idea of an ecosystem, I suppose, that lots of contributing factors. And we've talked a bit about that complexity tonight, haven't we? I certainly feel quite strongly about the organisational and regulatory issues. They've obviously got to be in place, and they vary around the world, but they can be very off-putting, particularly for clinicians working very hard on the ground with limited time. And I think we do perhaps need to bring, we're working with one walking technology that we're developing here at UEA, and we brought external regulatory advice in very, very early in the process to try to reassure, to understand the processes involved. But even so, it's been quite difficult to move from what we would consider prototype testing, but that the regulators consider clinical testing. So there's a lot of work to be done to change some of the language to help people to understand that, as I said in my presentation, those processes are in place to safeguard and to help safe and effective translation, rather than to be seen as barriers and create huge gaps. But I think it's really, really difficult. I think if you work for an organization that's really, really engaged, that can help. Just that feeling around the therapy team that working with technology is good and exciting and new, that's certainly a forward step. But not all organizations work that way.
Right.
Staff are really busy and really tired.
Yeah. Sujata, I'll let you get the last word in, and then we have about 9 minutes or 8 minutes left for questions.
I'm actually of the thought that some of the current bottlenecks are because of what Nicola is saying with institutional support, as well as the time that therapists need to figure some of this out. Because if you look at the commercial device space, And if you look at how many activity trackers are being sold daily and how many active video gaming devices are coming out every year, people are really interested in using these devices. Now, whether they have all the information that they need to be able to use these devices, if they have a health condition superimposed, that's a different question. And I think, that therapists need to take the time. Commercial devices aren't that hard to use. You just need to figure out if there is a small systematic error, what's your tolerance for that error? If you're tracking someone over time, maybe that systematic error doesn't matter as much, as long as you're just looking at, is there a behavioral change? Are they walking more today compared to yesterday? So I think the onus is, I feel like the onus is on us and on institutions to make to make improvements in the uptake of technology. I think people are definitely interested in using this more.
Yeah, I agree with you. And I think one of the ways we're doing that is by talking about it. And through this webinar, perhaps it's a way of exchanging ideas and opening some new ones. We have a lot of questions, so I want to move now to another one. This is a question from Paul Charlton, and he wrote, and again, Paul, you can unmute and join the conversation. And he wrote, it's a tough question. Do we have sufficient evidence to support best practice and understanding of our basic interventions before we start adding technologies? Who would like to address that one?
Can I put my question in context?
Yes, please do.
Thanks for taking my question. I'm an orthotist rather than a physiotherapist, and orthotics is probably the oldest technology around. And it amazes me how varied the uptake of involvement of orthotic intervention is with neurophysiotherapists. Some of them embrace it and use it as part of their treatment, and others feel that it impedes treatment and don't use it. So I can't help thinking that until we get some basic principles really sorted out and evidence-based, that all this technology is actually, it's a dream for researchers because there's so much to research, but for clinicians, there's such an abundance of choice and lack of clarity as to what the best way to go is. It's confusing.
Well, yeah, it is, but I think we're not looking at technology to replace therapy. I think we're using it as an adjunct to therapy. But I think the meat of your question is more related to what are we trying to improve using the technology, and I think that's where we get a little the lines get a little blurry because. Are we, Sujata, you mentioned, do they walk faster? Okay, that's great if they walk faster, but there's other questions too. Are they more stable? Can they deal with different environments, adaptively? So it's not just the big question of it's how they do it, and does our technology address that? And I think sometimes we're skipping over that step. Especially when, and this is a comment that Judy Deutsch also made, and I'm going to kind of paraphrase it, that the tracking error, how much can we tolerate a tracking error? Is it just okay to move anyway, or is it important to move the right way? And can we identify that? Can we use the technology to do that? Paul's, as an orthotist, is certainly interested in the quality of the movement and stability, which are factors very important for recovery of function. So I think this is where the problem lies. Is it just enough to do more, or is it what we do that's important? Sujata, I think you had made a comment about that. You want to elaborate? We have about 5 minutes left.
There are a couple of aspects to Paul's question, right? One is it helps us objectively quantify. So it helps us objectively measure, but just objectively measuring things with the use of technology is not enough by itself. So all three of us have presented these participant views, not just on the use, but also what utility they see in the use of these technologies. And so I think a combination of both those, the ability to objectively quantify and measure, as well as what perspectives does the participant bring, what some of their patient reported outcomes are, what excites them about the use of technology is important. So I think it's multiple aspects, and then this whole issue of how much error is tolerable. I think in pursuit of the most accurate device, sometimes we hold ourselves back in saying, "Oh, this is not the most accurate device that I want to use." But there's also a cost associated with it. I'll give you an example. My mom had recently had bilateral knee replacements, and she went and bought an activity tracker. And my dad always brags about how the devices that are available in India, where they live, are so much cheaper and have so many more features compared to the devices that I use. And so that's totally valid. Also, they're better supported in the country where they live in. And so I think that's an important consideration to make. Is this device going to be used? What's the point if you provide the most accurate device, but then the person is not going to use it at all? And of course, any activity is better than no activity. So just being able to monitor if that is improving over time, I think is a good start, even if it might not be the most accurate device.
Would the panel like to make any further comments on that?
I can comment from those studies that we did, the virtual reality. It was many participants said that the normal training, the ordinal training I do, it's boring. And this was not boring what I did here. So we have this enjoyment, and having a training in enjoyment way, so that's the one plus. And then I think we maybe need to look at the two different, what is the aim of the training? Is it just to improve, to be more active, just generally without thinking about how we use the body or movements are? And the other part, if you are targeting the movement quality and getting better, maybe there's different kind of systems you need to use then. But in both cases, I think you can use the technology.
Okay.
Yeah, I'm very aware of time, Mindy, but just to say all of the above, absolutely. And I think Paul's point is actually a really good one. And I know Bruce Dobkin wrote quite a pivotal paper about this some time ago, didn't we, about doing what we should be doing well. And I think we do. And I think, Paul, I would just say it's part of a toolkit for me. We have a toolkit that we use to enable us to apply the sort of principles underpinning neurorehabilitation. And if technology can be part of that toolkit,
exactly,
for the patient, then all to the good.
That's
okay,
great.
thank you. We do have to finish up, but I'm going to finish up with a comment made by Judy and commented on by others in the chat about teaching technology in the curriculum, and if it's not, obviously we need to bring it to the physiotherapist at that level in order to then incorporate it into physical therapy practice in the long run. So let's keep that in mind. And with that, I'm afraid we have to close the webinar. So on behalf of INPA, I'd like to thank our presenters and all of you who attended and participated, and thank you for your active participation. We'll be sending around a survey, and we would greatly appreciate it if you provide your input about future programs and that we can do in our global webinar series. So thank you once again, and a big thank you to the three presenters today.